here are the 5 AI claims I hear most often in health systems. AI conversations and why each of them requires absolute scrutiny before you sign. So first, I love it when vendors say our AI reduces physician documentation time by 40%. How many times have you heard that? So sometimes it's true. And in controlled pilots with motivated users at specific documentation types on specific EHR integrations, the claim fails when it hits the production environment. Different EHR configuration, variable physician adoption, documentation types that the pilot didn't really cover. So that 40% becomes like 12% for the physicians who use it and 0% for the physicians who root around it. So the overall metric looks like 18% and the vendor calls it a success. The second claim is our predictive model identifies high-risk patients before deterioration. I mean, I might be one of the people that's completely responsible for putting this out in the market too. But the OROC on the validation study, it's impressive. What the slide does not show is the alert burden that model actually generates at your patient volume. I've watched health systems deploy sepsis prediction algos that fired alerts at a rate that nurses stopped reading them. Within 3 months, the workflow integration was not. Alert fatigue is not a technology problem. It's a clinical design problem that technology vendors don't own. Implementation takes 90 days. When's the last time you implemented anything in 90 days? This is a timeline to technical go live. It's not the timeline to meaningful adoption. Those are two completely different numbers. And the second one is typically 12 to 18 months longer than the vendor projects. The 90-day claim is accurate and incomplete in the same breath. And then claim 4, and again, guilty as charged, our tool is EHR agnostic. This means it integrates via HL7 or FHIR. It does not mean the integration is seamless, fully bidirectional, or that it surfaces outputs in the actual clinical workflow where decisions get made. EHR agnostic is a statement about technical standards, not about clinical usability. Claim 5 is our model was validated at insert your prestigious health system. Validation in a major academic medical center with a dedicated implementation team, our research infrastructure, and motivated physician champions does not predict performance at a community hospital with 3 IT staff and a clinical team that is already at 110% capacity. The validation is real, of course, but the generalizability, that's the question your vendor is not actually answering.